The following presentation is a production of Ride the Wave Media.
It's the Best Birth Podcast, where we interview experts that elevate you as you prepare your heart and mind to have the best birth.
Each episode will interview professionals so you are prepared for pregnancy, birth, and postpartum. Our experts will build your confidence and empower you to trust your intuition throughout your pregnancy.
This audio is taken from videos on YouTube. Watch the entire episodes on YouTube at Birth Made Mindful. You're listening to the Best Birth Podcast. Today we have Dr. Jonathan Crowther. He is our resident doctor of the podcast, and he'll be talking all about trimesters 2 and 3, what to expect, and when to see your provider.
Dr. Crowther is a husband, father of 2 little girls, and in his spare time, he is in his final year as an internal medicine resident physician. He lives in Castle Rock, Colorado, and practices medicine out of 3 hospitals and a primary care clinic in Denver. While he has resorted to specializing in internal medicine, he has a passion for supporting and encouraging women who are currently navigating through pregnancy, birth, and postpartum. He had the great pleasure of delivering multiple babies during medical school, but of course, his favorite experiences were helping to deliver his own 2 baby girls, Kinsley, now age 3, and Raylyn, now age 1, whose birth stories were both unique and life-changing. Welcome, Dr. Crowther.
Yes, thank you. I'm glad to be on again.
We're excited to talk all about trimester 2 and trimester 3. And I would just like to note that trimester 2 is my favorite trimester. I was one of the lucky ones who did not feel morning sickness during my second trimester, but I know many do. So please be gracious with yourself if you're still feeling nauseous. I mean, many of my friends, they were in their 9th month and they were still praising that porcelain goddess.
Yes, yeah, I can imagine. I cannot speak from experience, although I think I maybe had empathy morning sickness one day.
Did you ever hold her hair?
I will say yes.
We'll take it.
You get the gold star.
Right? Yeah. Usually it was kind of interesting because Carly would have morning sickness more at night, which is very common for people, even though they don't really have the morning sickness. It's the evening sickness. But yeah, so today just wanted to talk a little bit about our prenatal care, and a lot is going to be the first or the second and third trimester, but there's some things that we kind of went unanswered with the first trimester as well, so I might add a couple things there. But yeah, prenatal care, basically, the 3 big goals of it when you're looking for someone to get help navigating through pregnancy, you and your provider they're going to be looking at, risk assessment. Are you going to be a high risk pregnancy, a low risk pregnancy? Provide health promotion and education, because it's like drinking out of a fire hose sometimes with getting the information. And therapeutic interventions. Are there any things that need to be done so that both mom and baby can be as healthy as they can be? And there's a good quote that I have here, just saying, high quality prenatal care can prevent or lead to timely recognition and treatment of maternal and fetal complications. Complications of pregnancy and childbirth are the leading cause of morbidity and mortality in female of reproductive age globally. So the main goal is to help ensure the birth of healthy newborn while minimizing maternal risk. So if you think of it that way, that really the health of the baby, I'm going to these doctor's appointments. It's for the health of the baby, but it also help for mom, because it is the leading cause of passing away and mortality for pregnant age women globally, which is kind of interesting. So in general, the question is, when do we first start doing prenatal care? And ideally, it should be initiated in the first trimester, usually by age 10 weeks of gestation. When you are meeting with a provider, it's kind of a little bit of your choice on who you see. But I will kind of lay out the providers that will see patients of this specialty. The the special pregnant patients. um, you have midwives and family medicines, which usually see patients who have where major complications or high-risk pregnancies are usually not anticipated. OB-GYN or obstetrician-gynecologists are also those who can see uncomplicated and some complicated pregnancies. And then you also have maternal fetal medicine subspecialists who are obstetricians who actually go through more training with expertise in managing high risk and complicated pregnancies. So when you're talking with your provider, with all the information that they'll get from you with these screening exams, they can let you know, are you high risk, medium risk, low risk? And are there any anticipated complications with your birth? And then the other one that we can't forget with our birthing partners is going to be prenatal doulas and prenatal educators, which you guys are part of that community, who provide both the education and support. And a lot of times, working one-on-one with the patient, they serve as a coach, they serve as an advocate, they serve as somebody to rely on. And it's a really special kind of relationship that you can have between the two of you.
Myself and Sarah both delivered all 3 babies at different places, so that's always interesting as well. Changing providers. I delivered my first baby in Idaho. That's where my husband was going to school. My second baby was at a hospital. And my third baby, I did have a high-risk pregnancy, so I was transferred to a specialist at a university.
Yeah. Kind of similar with our experience. My wife and I, we, had our first in a hospital. And then our second one was going to be at birthing center and didn't make it to the birthing center in time. And so baby was born at home. And of course, Carly did all the work. All I did was catch, but kind of a special thing.
Those babies are so sneaky. They come when they want to come.
Yeah. I will tell you a funny story just about kind of my perspective of our first child. So this is when I was naive and not a parent. And the nurse at the hospital was like, okay, this is your last sleep before having a baby, because we were doing Cervidil, which is a type of, induction form, but it's a very relaxed kind of way. It doesn't it's not like Pitocin. It doesn't just hit you right into labor. They're like, yeah, it'll probably take about 24 hours for it to kind of kick in, kind of allow for the cervical ripening and allow for contractions to then hopefully start naturally after that. And so tonight's going to be your last night of good sleep. And so I was like, okay, I'm going to take a sleeping pill. So I took one. And then 2 hours later, Carly goes into full labor. And this entire time I am fighting sleep during the labor of my wife and our firstborn child. And so I was just praying to God. I was just praying like, Lord, please don't have me fall asleep while my wife is laboring. Number one, it's rude and I don't want to get in trouble. And then my prayer just changed to like, Lord, if I do fall asleep, just don't let her notice.
And were your prayers answered?
They were. Yes, very much so.
My first was born in a hospital and second in a birth center. My third little boy was born at home. So I have a lot of different providers that I worked with and am grateful for all of them and the support that they gave to me. I did allow my husband to sleep when we had our home birth. I told myself, I don't want anybody to have to be up in the night if they don't have to be. So I forced myself to sleep and I let him sleep for about 5 hours while I was laboring. So I even went to a different bed because I am that kind of woman.
Wow. That's dedication there.
Well, we were lucky enough to have a guest bed that I could go and kind of wiggle and writhe while I was having those early contractions. But lucky for him, when the midwife came, couple hours, 10 in the morning, I had progressed to 8 centimeters. So then My husband had the crazy job of trying to get everything ready, fill the birth tub, call the birthing photographer, make me my smoothie. So it was kind of a whirlwind, even though it was not a quick delivery of your wife's.
Yeah. Well, thank you for sharing. Um, well, I guess I'll just jump in. I won't be too specific on timing of things. I'll give a little bit of timing here and there, but essentially, you're going to come in. You're not going to really know what everything happens, but there's a lot of things that will happen within your first, second, and third trimester, and a lot of it has to do with screening. Um, and so screening has to do both with using ultrasound, evaluating the baby, as well as blood tests, and even as far as doing chorionic villus sampling or even amniocentesis. So just a little bit about those, because a lot of people don't really know too much about those. But the chorionic villus biopsy or the amniocentesis, these are invasive procedures that are done by an obstetrician. And basically what you're doing is you're checking to see if there's any, you can actually check and see the sex of the baby during that time, but you're looking for DNA sampling of the baby. And, my kind of take on it is maybe different from others, but in general, what they're screening for is chromosomal abnormalities. These are patients with trisomy or Down syndromes, Edwards syndromes, Patau syndrome. And the question then becomes, if they are positive for that, what do you do then? Do you choose for elective abortion or not? So that isn't your plan. Then a lot of the times these can be foregone, and you can actually go ahead and do, but if you're still kind of curious, you can even do serum testing, and you can do DNA testing of the mother's serum, and you're actually looking for DNA of these chromosomes within the serum if you want to know that way, instead of having to do the invasive procedure. Other screenings that we do is we check blood type, and that's important for looking for people who are Rho positive or Rho negative. And you guys know plenty about that, I'm sure. But essentially, for those who may not know, it's basically the Rho is a immunoglobulin that can be antibodies against this marker on your bloodstream, and it can make it or baby at risk. If you are a Rho negative parent, it makes you at risk for developing antibodies against a Rho positive baby's blood type. It's not really much of a problem for baby number 1, but the problem comes on with baby number 2 or number 3. If they then again have a positive Rho on their blood and you are still Rho negative, then you can develop autoantibodies, and you can actually cause a type of a hemolytic anemia on the child, and it can be devastating, and it can be fatal for the baby. So it's a simple test that they check for that, and then they look for any sort of antibodies that are being made, and then you can get a immunization shot, which prevents you from making those antibodies. Other things that you're going to be screening for is you're going to be looking for the hemoglobin hematocrit. Remember in our last episode, we kind of talked a little bit about that physiological change of anemia. But there can be actual anemia that happens for those who are pregnant. And so, looking at that, looking at your mean corpuscle volume could indicate whether or not we need to check iron levels. If your iron levels are low, then maybe it would be good to get on a iron supplement, and then have that contribute to your constipation that you're already having from those normal Yeah, so for those, you do that high fiber stuff. I would add on like things like Metamucil is very good. It's, a fiber,
That'll
or
definitely work.
that'll work. Even Seneca could be helpful in those situations.
And all of these tests are performed with the blood draw that is performed at most of our
Yep.
visits, our prenatal visits.
And it kind of depends on when you start your initiation of these prenatal visits, when you'll get it. There are some specific blood draws, but I'll kind of just go through a slew of, other things that they'll do. They'll check a urine. They'll look for urine in your protein. That will tell you them later on if you develop any sort of signs of a preeclampsia or eclampsia later on, if you already had protein in your urine. They'll do a urine culture and just make sure that you don't have any infection that needs to be treated. And they also look for group B strep in that urine culture.
And the tricky thing about those urine tests is it's a fine line between having enough in your bladder and not having enough. I remember just going into the doctor because I'm not sure if they want a urine test or not. Oh, we'll get it out of the way so you can be more comfortable because you need to pee a lot.
Yeah, exactly. So
It seems that I was required to give a urine sample every time, so I
Yeah.
just started planning on it.
that's a good advice. Just remind yourself when you're drinking that water, just wait on having to pee until you get to the doctor's office and
If you
pee
can.
in one of their cups. These are new moms. They usually very healthy, and coming and seeing a doctor for the first time. This is an opportunity for us to get other healthcare things that are going to be better for the mother in the long term. So cervical cancer screening is, something that also may occur. Either they may wait, or they do it kind of early on in pregnancy and they just do a pap smear. They'll check you for things like STDs, bloodborne diseases, HIV, syphilis, hepatitis B, hepatitis C, chlamydia. Now, the big question that people will have, well, I'm monogamous. I don't necessarily have a second partner. I don't trust my patients as far as I could throw them. But also with these conditions, it's better just to know for sure that you're negative for these, because having blindness of your child because you didn't get screened for chlamydia or gonorrhea or something like that is something that's going to be helpful.
Will a provider typically recommend a C-section if you show a positive response?
So there's a couple of things that they would recommend you having a C-section. The chlamydia, if it's untreated. So if it gets treated, then you should be fine. And then they can just treat the baby's eyes once they get out. For things like herpes simplex, if there are active lesions within the genital area, then that is an indication for a cesarean section, just because there isn't a way to protect the child other than by doing a cesarean section. Other kind of not very common ones for our country that we don't have to worry about as much are things like measles, tuberculosis, toxoplasmosis. But essentially, we get that because we get vaccinated. So make sure that all of your vaccines are current, and they'll make sure that happens as well. One of them, for sure, being the Tdap. They could also screen you for Zika, or just make sure that, we don't live in an area that's for that, but they'll recommend you not go to endemic areas where Zika is, just because of the birth defects that can occur from Zika. And then another thing that is generally screened with these visits is mental health. Checking to look for depression, anxiety. It's very important because, number one, you're going through a lot, and as it is, and especially for those who may not have as much support, it's important to be screened for that, because there's easy treatments for that, both medication based, but also cognitive behavioral therapy. that can be very helpful in supporting mothers who are new time moms.
And then towards the end of the third trimester is when you start to go weekly if you're in a hospital for those checkups.
Yes.
Yeah, is that just because birth is imminent? Is it there's more risk factors towards the end?
Exactly. So, the reason for it being, in general, the first and second trimesters, they may say every 4 weeks. And then in your third trimester, they might say every 2 weeks. And then when you're in the last 4 weeks, they'll have you go every week. And two things, they're checking for mom and we're checking on baby, making sure that there's good fetal movements, going on. And there's also the very fun Group B strep that has to happen, as well as your checking for your diabetes, pregnancy-associated diabetes. So they'll do those kind of screening tests because later on in the pregnancy, that's where you could have things where if you had diabetes and it was unchecked during pregnancy, then baby could actually become too large and then be a problem for just a normal, uncomplicated vaginal birth. And so that's why we kind of check for those things.
It's amazing to me how much data and how much information is gathered from these appointments just by simple blood extraction and urine and physical exam.
Mm-hmm. Yeah, you don't think about kind of everything that happens behind the scenes, but there's just a whole lot that kind of goes on behind the scenes. And then you pair it with the intermittent kind of ultrasounds. If there's more concern about a baby, maybe not showing as much movement, then doing a non-stress test on the baby is another way of being able to see how is baby doing, how's the baby's growth, is there any growth restriction, is there too much growth? There's a lot to kind of take into consideration there.
I had ultrasounds a lot more frequently with my third because I had placenta previa and they were checking my scar area to see if the placenta was trying to burrow into those scars.
Right. Yeah. Yeah. That's an example. Cause they want to see if baby will be able to be vaginal or not. And then, the big hope that you're having in those kind of later weeks and like 36 weeks to 41 weeks is going to be if baby is cephalic or not, meaning is baby's head down or is baby's head up? Because offering an external cephalic version or being able to actually manipulate the baby could be something that that providers can offer as well. So there are a couple, signs and symptoms that you should be reporting to your healthcare provider. One is going to be vaginal bleeding. Okay. Vaginal bleeding is something that can occur in any of the trimesters. If it's kind of earlier in the trimesters, it could just be from implantation bleeding. It could be from a subchorionic hemorrhage. It could be from threatened miscarriage. It could be a sign of miscarriage. So those should be checked out. If there is associated pelvic pain, that should also be something that is evaluated as well. And a lot of times they'll do transvaginal ultrasound earlier in the pregnancy course in order to make sure that there's not any sort of ectopic pregnancy or even twin pregnancies, maybe one that's inside the uterus, another one that's ectopic. They're looking for a lot of things or ruling out a lot of things. And hopefully it's just normal laxity from the musculoskeletal system. That's what they're hoping for. Right? If you're noticing any sort of membranes where you're having more clear fluid, that could be something that you'll want to talk with the provider because you may be in a preterm or pre-labor kind of situation. Any sort of decreased fetal activity, you feel them moving around and then it's not as much, that's something to be checked out. If you're having abdominal pain, especially abdominal pain that is sharp and severe in nature and unrelenting, meaning that it continues, because that could be an emergency that may need to be addressed.
And for most of these situations, would you recommend that we call the office that we're seeing and just see if they can get us in, or would we ever need to head over to the ER?
Yeah, it depends. If you're having sharp abdominal pain, and then you're starting to feel nauseous, you're vomiting, you're feeling dizzy, you're feeling like you're going to pass out, in that situation, you're just going straight to the ER to get evaluated. And hopefully it's nothing, but it is something to take in mind, especially for those who have, had prior C-sections. They are at more risk for uterine rupture. It's a little less of a risk than kind of what previously it had been thought to be with cesarean sections and those who are trying to do feedback. But it still is a risk to and a higher high risk pregnancy.
Are there any other situations that we'll want to notify our provider?
Yeah, definitely. Big things that people don't really think about are, headaches that aren't relieved by having a dose of acetaminophen, or if you're having any sort of visual changes. And if you're noticing, your blood pressure is spiking, you check it at home. Those are all signs of preeclampsia. And preeclampsia is the lesser evil of eclampsia, which is essentially headaches, high blood pressure, that then results in seizures for the mom. And so that's where, being evaluated and making sure that your blood pressure is under control. And a lot of the times, depending on how many weeks that you've been in, could result in earlier induction of labor to treat that preeclampsia. So that way that you don't have the complications of eclampsia. I like to tell, anybody who's kind of questioning, when in doubt about your symptoms, it's always better just, a phone call to your provider is appropriate if it's not something that you feel like is, severe in nature. But don't just try to do this on your own. Create your healthcare team. And whether that is your team consists of your doula and a midwife, or your family medicine doctor, or whatever it might be, just know that they are there to support you during this time.
And oftentimes a provider can use telehealth, text messaging, calling to kind of find out more. You might not have to immediately drop what you're doing and head somewhere, but you can get the assistance needed.
Yeah, exactly.
I remember having to leave a couple voicemails for mine, and then they would always answer within the day, but that's a good reminder. We'll just share our Mom Squad secret for the day. This one's from Megan, and she says, if you are experiencing high blood pressure, increase your protein and look into the Brewer's diet. Cod liver pills may also decrease your blood pressure. Have you found that would help your blood pressure, is increasing your protein? What does that do to it?
Blood pressure in this case, there's a lot of things that can just help your blood pressure normally. You think of essential hypertension as essentially separate from a pregnancy type of hypertension, which actually occurs at the spiral arteries with the connection between your placenta, mom's and baby's blood right there. So once you have preeclampsia, the treatment will be, more medication based. Now, taking supplements that have known to have a good effect on blood pressure can't hurt. but it may not do everything to help. So if you truly have, high blood pressure in pregnancy, it should be something that is managed with blood pressure medications, because that will make you at more risk for having preeclampsia.
This has been a wonderful conversation. Is there anything else you'd like to add for our second and third trimester?
This is the time to kind of utilize help with physical therapists, with chiropractor, maybe even acupuncture has been known to help if you're kind of suffering in pain. The musculoskeletal pains that just happens from that laxity and everything else can be addressed through those forms. Regardless of who you choose as your provider, what you want is, somebody who's going to be doing evidence-based medicine. So for example, me being a physician, I know maybe too much to be dangerous or whatever, but we felt completely comfortable with our second baby being seen and managed by a midwife, because of Carly's first pregnancy was largely uncomplicated, and so was the second one. And so it's something to keep in mind, but still, it's important that whoever is giving that care isn't overlooking things like these important screening tests, such as the Griffey strap, the checking your blood pressure, screening for diabetes, and that and the like.
And if your intuition is prompting you to inform your provider of something that you feel inside, that's always something to follow as well.
Mm-hmm. Yeah, very much so.
Very well said. Well, thank you so much for being here. We really appreciate you sharing your expertise and continuing to be our resident doctor.
Very much so. I'm glad to be here.
Thanks for joining us on today's episode. We hope you've been elevated and inspired by this week's expert.
Subscribe today so you never miss an episode. And please share our podcast or post on your social media so that other moms and dads-to-be can also have the best birth.
Please note that the information provided is based on the expert's insights and personal experience. It is not intended as medical guidance. Please seek the advice of your medical provider as it applies to your specific condition.